Okay.
Hi.
Hello, Dr. Mustafa. How are you?
Hey, how's it going? Sorry, I was in the OR and I just finished,
Oh,
so sorry if I'm late.
yeah. I was explaining to our audience that you guys are just so busy in clinic and in the OR. And of course, our patients are the highest importance. So I totally get it. And
Thank
I
you.
appreciate your time today.
Thank you. Thank you so much, Gabby. Always fun talking to you.
Yeah.
Very exciting.
And I just love learning about all these different conditions that you guys are able to treat and guide patients through. Today, we're going to be talking about placenta accreta spectrum. And I wanted to start off for those watching to have you explain a little bit, summarize what this means for a patient if they have this diagnosis.
Yeah. So that's a very interesting topic, and I'm sure moms who had it is going to be very relatable to them. When Gabby reached out, like, what should we talk about? I mean, it just made sense to talk about something that could affect mom's life, and what is more than placenta accreta spectrum. So what is it basically? Placenta attaches to the uterine wall or invades through the uterine wall. That makes it hard for us to remove after delivery of the baby and requires us actually to do hysterectomy, the only way to do it after delivering the baby to save mom. Otherwise, you could have severe hemorrhage that ends up with severe complications, including ICU admission and maternal mortality. So today we're going to talk about this very sensitive, very important topic that hopefully so many will get some knowledge and share the knowledge with other moms as well.
Yeah, because I imagine if you've never heard about this and you get that diagnosis, it's scary. It's overwhelming. So, right, empowering people through information so that if they have a loved one, if they themselves go through this, they have an idea of what it all means. And so how does this get diagnosed and when does that happen typically in a pregnancy?
Good. So back in the days, we used to mainly diagnose these cases around anatomy ultrasound time or like later. Sometimes it could be even hard to see around anatomy ultrasound. And that's because this is the time that moms present for ultrasound most of the time, which is around 18 to 22 weeks. Nowadays, with the introduction of first trimester ultrasound, and we do it more often. We educate our patients about the importance of first trimester ultrasound. We are able to see earlier cases. And now, nowadays, back in the days where something was called cesarean scar ectopic, which is seen very early in pregnancy. Now, so many people think that placenta accreta is some sort of progression or spectrum of cesarean scar ectopic. So it most likely presented really early in pregnancy, and then by the time she came to us, there's a big placenta, and it shows as accreta, basically.
Wow. And so for a mom that's dealing with this, what are the potential consequences, right? If this continues, if there's no game plan there, what can happen to a mom that has this?
Yes, very good question. So it depends really on how many weeks is she, how bad is the placenta accreta, did she have any symptoms, how is her pregnancy going? But generally, once you have a placenta that is severely attached to your urine wall or growing through the urine wall or outside of the wall, because it doesn't separate, really contractions could predispose you to heavy bleeding. Around the third trimester, the uterus gets almost half a liter blood a minute. So really, any hemorrhage, meaning you're losing all your blood in very short amount of time. So aside from hemorrhage, really the severe consequences is maternal mortality. And if it was undiagnosed cases, if it was delayed presentation to the emergency room, then unfortunately we lost a lot of moms because of that. Some of the moms where they get transferred to us to Riley Children, sometimes they get transferred to us pretty late where they got already like 30 and 50 units of blood, and we try our best, so we still lose some moms if it was a delayed or not diagnosed and late presentation to the hospital. So hopefully nowadays with the introduction of all these ultrasounds and increase the expertise in diagnosing these cases, our outcomes are much better, thankfully.
And are there certain patients that are maybe predisposed or at a higher risk of having this condition?
You asked excellent questions, Gabby. I love you.
I'm glad. I'm like former journalist here. I'm trying.
So this question question. When I do like presentations to general OBGYNs or even other MFMs, this is the point I focus on. Because you can always do an ultrasound and look at the placenta, okay. But like for placenta accreta, you have to have some level of suspicion to look really well, sometimes even do MRI. So when do you have that level of suspicion, which is risk factors, which is your question. So prior C-sections, the more you have your C-sections, the more it increases your risk for placenta accreta. Placenta previa, meaning the placenta is covering the os of the cervix or the birth canal where the baby comes from. We call it a placenta previa, so the placenta is very low. That's a huge risk factor. So these are the two most important risk factors. You have C-section in the past, and your current placenta is placenta previa. Aside from that, any uterine surgeries in the past could put you at risk. DNCs, you had infection to the uterine wall that caused scarring tissue. IVF pregnancies by itself also risk factor. Multigravida, meaning having multiple pregnancies, even if they were not C-section, put you at risk. And so many other factors. But what we always counsel, mainly, if you have prior C-sections, and placenta previa, or sometimes the placenta just a little bit low, that was close where they did the C-section scar in the past, look for the placenta really well, bring the patients for another ultrasound, do MRI if you're in suspicion, and pick these cases to manage them appropriately.
Yeah, good to know right there, especially as patients to advocate for themselves, right? If they know that they've had these situations in the past. And I'm sure many parents are wondering too, if they have to deal with this, what are the risks to baby, you know, if this is the condition that a mom is diagnosed with?
Correct. So whatever happens to mom, unfortunately, affect the baby. So if mom ended up delivering early, then we're dealing for risks of prematurity. Like if it was really early, so we're dealing with respiratory issues, feeding issues, brain issues, or everything related to prematurity. If mom bled heavily, that she became asphyxic or she needed ICU admission, and that will affect the blood supply to the baby and may put the baby at risk of demise. So really, if mom ended up having severe complications, then the baby might be affected. However, the cases that were diagnosed appropriately, were followed appropriately, we see them very frequently, and we deliver them or manage them at the right time, babies do fine.
I'm sure that's such a relief to hear for these parents as they're navigating all of this after getting that diagnosis. And then my question to you is also, once, if a patient is, you know, diagnosed early and followed and a game plan is put in place, what does that look like, that course of treatment, or the way that you guys are able to help that person make it through that delivery? What happens then?
Awesome. Yes. So obviously, like you said, at the first visit is very overwhelming. I have so many of my patients cry when they come to us, even though we are a referral center. So basically, whenever someone has a suspicion for placenta accreta, they refer to us. We have a placenta accreta program here. We're going to talk about it a little bit later, but we get a lot of these referrals. And even though they heard it from their provider, they come to us and most of them, they burst in crying, obviously, which is very appropriate, given that maybe we also overwhelm them with information. So the first visit is the big visit where we do ultrasound, we might do an MRI, we make sure yes, it is accreta, but aside from it's accreta, how bad it is. Is it just attached to the uterus? Is it in the wall of the uterus, what we call accreta? Is it outside of the uterus, what we call percreta? Is there other organs that are involved? Was the bladder involved? Was the bowel involved? And all these information will help us also how often we follow these patients. Do we need to keep them in the hospital until delivery? Do we need to deliver them pretty early? Can we push the pregnancy a little bit farther? So then we will make a game plan with the patient. Most of the time we follow them very frequently, not necessarily with ultrasounds, with OB visits as well. They need to see their OB physician very frequently. If they have any complication, any bleeding, any contraction, anything that doesn't look right to them, they have to report it either to OB or they have to go to the nearest emergency room. Even though most of the time we recommend delivery at Riley because these are very complicated cases, but I say whenever something bad happens, go to the nearest hospital. They will stabilize you, and if they can, they will send you to us. So ultrasounds, OB visits, And then we're going to talk about delivery timing. Delivery timing, we love if we could deliver between 34 and 36 weeks. Maximum is 36. We do not go beyond that. We love if we could arrange the delivery between 34 and 36 weeks. However, some cases which present with bleeding and complication, unfortunately, we end up delivering them early. But those cases that we follow them very closely and we pick any complications early, they tend to do fine and they make it all the way to 34, 36, even though it's a preterm, but the outcomes are amazing. So other than some breathing issues, some feeding issues, babies do fine.
That's great. And so the way to deal with this condition, does that always require that hysterectomy you were talking about? Or
Yes.
I guess, what is the protocol there once
Yeah.
baby is out and delivered safely?
Excellent, excellent questions. So management of accreta is hysterectomy. That is like rule of thumb. There is some only few exceptions, and we can talk about them. And this is also kind of part of our program when we talk to our patients. We always emphasize that this is a surgical diagnosis. So even though my imaging says accreta, my imaging thinks this is percreta, but it's not involving the bladder, etc., or involving the bladder. It's really at the time of surgery when we decide how bad it is. Okay, cases are managed by hysterectomy. Only very, very rare. If this was first pregnancy, it is focal accreta, where we call basically tiny bit of the placenta that is attached, but everything else is not attached. Mom really want to preserve her fertility. Then we tell them, we will aim of what's safe for you. If it was safe to resect that tiny bit of placenta, then to take out your uterus, because hysterectomy is a major surgery, very bloody, very invasive surgery. So if it was safer for us, for that tiny portion we'll cut it, then that is okay. But really, aside from this very exception, hysterectomy is the way to go.
Okay, got it. And to have specialists like yourself and your colleagues at Riley, why is that so important for these moms that are getting referred to you guys to have the right plan in place and the right people for a surgery like you just mentioned can be very complicated and bloody and all of these things?
Yes, excellent question. So the answer to that, the multidisciplinary management is not a one-person job. This is very, very complicated a pregnancy. We need a big team. We need the team that diagnoses. We need the team that delivers. We need the team that if you needed, we had a patient, like let's say she needed 100 units of blood. Our blood bank was able to do that. So you have to have a blood bank that is able to give you as much blood as you want. You have to have an ICU that is available immediately if you need it. For example, in our hospital, on our labor and delivery, right outside the door of the operating room, we have 3 ICU rooms covered by 24-hour critical care physician. So I always tell my patients, is not the surgical part alone. A lot of the physicians everywhere, they're excellent surgeons and they could do the surgery perfectly, but it's really the pre-op care and the post-op care. After you deliver, after they do surgery, what if you needed a blood? What if you needed ICU admission? What if you needed a general surgeon because the bowel was involved? What if you needed a urologist because your bladder or the ureters were involved? Our team has urology, general surgery, vascular surgery if we wanted to do vascular occlusion. We have radiologists, we have MFM, and our GYN oncologist, a critical part of our team, who gets involved in these cases because it's so invasive, the placenta sometimes. So having that big team, you get great outcomes. You cannot make it a one-person job. Then your outcomes obviously decline.
It's just amazing to hear how many people are involved in this type of case and that we have them all under one roof for patient.
Even anesthesia team, our anesthesiologists who deal with these cases, they are very specialized and trained to take care of these patients. This is not just like a regular general or a regular epidural or spinal anesthesia. These are critical findings that you have to be on top of, vitals, sending labs, knowing when to give blood, knowing how to stabilize an unstable patient. So the anesthesia team, everyone is basically expert people in taking care of these patients.
It's so good to hear. And if a parent is watching this and perhaps they just got that diagnosis as a family that mom has this condition. Any quick words to share with them? You know, you've kind of walked us through what the process looks like and what it means, but just those
Yeah.
words of reassurance, I guess, or guidance for them.
What I always say, when you get diagnosed, when you get followed appropriately, the outcomes are good. Outcomes are great even sometimes. Advocate for yourselves. Make sure if you have anything that doesn't look right to you, go to the emergency room immediately. Even if it's just a tiny blood, some contraction, do not hesitate. Advocate for yourself in sharing your OB history appropriately. If you had C-sections, if you had any complications, when you present for your OB visit the first time, make sure you tell them everything about your OB history, about what happened to you in the past, any surgeries you had, to make your physician aware and to manage you appropriately too, as long as they're aware of what happened to you. And then be assured that there's so many centers nowadays all over, including our center in Indiana, that could take care of such a complicated case. So I would definitely make sure that I've been managed by a team that is equipped to take care of these cases, especially a multidisciplinary team, like I explained before.
Perfect. Well, thank you so much. I think this has been eye-opening. We've had a lot of people joining throughout this conversation, and this will be on our feed for anyone that watches later on. We did have one quick question in the comments, so I want to share that with you. Marina asked, are all maternal fetal medicine doctors surgeons? They were just wondering about that part.
Okay, so let's talk about who are MFMs, or maternal fetal medicine. Some people use the term perinatologist. Some people call high risk obstetric, but is like on paper is maternal fetal medicine. So they're originally OBGYNs. So we finished OBGYN residency. Then you do an extra training fellowship and you become an MFM. So they were all at some point surgeons. We all do deliveries, we all did GYN surgeries. However, we decided to subspecialize in taking care of high-risk moms only. So any surgeries that we do as MFMs is related to mom being pregnant. So we don't do any more like GYN surgeries, like anything to the mom herself, like to the woman herself, but she's not pregnant. So these are usually by our colleagues, gynecologists. So we do perform surgeries, but it's mainly related to high-risk pregnancy.
Great. Thank you for clarifying that. And that's what's so cool about these Instagram lives. People can interact with us as we're having the conversation and just have direct access to people like you who are so knowledgeable in this field. So thank you so much for your time, for just diving into this topic. And I'm sure it'll help people that are kind of walking this journey now. So thanks so much.
Yeah, thank you, Gabby. Always fun talking to you. Always ask amazing questions. Gabby asked me, should I focus on something? I said, Gabby, you always do it. Amazing job. Just do your thing. It's going to be
Thank you. Thank you. Well, you guys make it easy. So I appreciate your time, and I'll let you get back to that busy clinic and OR and all that fun stuff. So have a great day.
Thank you.
Bye-bye.
Bye-bye. Yeah.